Hey everybody, welcome back. Let's go through the clinicals of vision. So, blindness, cataracts, all the good stuff. So, going through the visual defects, first most common one is like diplopia, which is double vision due to ocular misalignment. There's a variety of causes. It can be trauma, it can be like congenital, but there are different types as well, such as monodiplopia. So that's going to be double vision in only one eye. That's usually caused by like cataracts or strokes. Amblyopia is going to be lazy eye, and this is usually congenital due to abnormal development of the eye muscles, and that usually causes dimness of vision. Unfortunately, if not corrected, the body will compensate by shutting off the vision to that entire eye completely. So eventually the person will go blind in the affected eye due to the misalignment and the constant the stimulation is too high, right? And the body can't reconcile the images, so this patient is going to be dizzy a lot of the time, or not just dizzy, but they're just going to be unable to even form the visual field correctly. The depth perception will not be there. Strabismus can be a part in it, especially if it's severe. Usually, this is a physical deviation of the eye. In extreme cases, like here, esotropia, so one eye is going to be crossed inwards. Exotropia is when one eye is going to be deviate outwards. These are going to be your more severe form of amblyopia, and of course, is going to cause the double vision problem. Scotoma is going to be a partial loss of vision, and it can be a variety of different ways. Either there's can be like a tunnel, or there's black spots, or there can be blurred parts of the vision. Neglect. Okay, so neglect is usually caused by a pretty big stroke, and that's the failure to orient, to respond, or report stimuli present on the side contralateral to the lesion. It's not caused by hemianopsia or the loss of sensation. So these are just symptoms that are associated with it. What's more important to know is that neglect is not all or nothing. It can vary in its severity. It could be either like tactile, visual, auditory, and it can even involve motor components. So the patient may not be aware of their head and posture, and they have problems crossing midline and difficulty visually fixating into a sign or another. Retinitis pigmentosa is a hereditary visual defect where there's a degeneration of the photoreceptors and inflammation of the retina. As you can see here, all these like spots. This is the pigments. It's a mutation of about like 30 genes, and all of that causes a narrowing of the retinal vessels and the formation of these clumps of pigment released from the retinal pigment epithelium. So remember, that's like the outermost layer. The clumps are going to be formed near the retinal blood vessels, and then the bony spicules will form. So here we go. And then it's a degenerative process. So first you will lose the rod, so your visual acuity is going to be decreased, and then you start losing the cones. Argyll-Robertson pupil is going to be a damage to the Ehninger-Westphal nucleus, and that could be caused by diabetic neuropathy or neurosyphilis. Diabetic neuropathy is a lot more common. So there's going to be a damage to the tecto tract by the syringomyelia of the aqueduct of Sylvius, or once again by neurosyphilis. So in this case, there aren't any reactions to light, and it's hard to dilate, and the pupils do not constrict either. So that's going to be a problem with the light reflex. However, accommodation is normal. The pupils will constrict when an object is brought closer. So that is Argyll-Robertson pupil. Addie's pupil is going to be a lesion of the ciliary ganglia or the postganglionic fibers of the short posterior ciliary nerve. So in this case, the pupil is tonically dilated, so they're always dilated. And before, there's going to be problems with dilation. However, this is going to be constriction for accommodation. So like same as the Argyll-Robertson pupil, the response is normal for a near object. There is normal accommodation, but no constriction for light. The difference between these two really is the lesion area. And so this is going to be a problem with the ciliary ganglia, and the other is going to be a problem in the Edinger-Westphal nucleus. Weber syndrome is going to affect the rootlets of cranial nerve 3 at the junction of pons and medulla, and it's going to cause an ipsilateral squint and diplopia, along with ptosis and proptosis. And it's usually caused by a mid-brain stroke of the posterior cerebellar artery. And the squinting and the ptosis is going to be due to the paralysis of the levator palpebrae and the medial rectus muscle and the superior levator palpebrae. So the pupil is going to be dilated and non-responsive to the light reflex due to the involvement of the Edinger-Westphal nucleus. And there's going to be it's going to be accompanied by contralateral upper motor neuron paralysis. So there is going to be a paralysis of but just like the lower jaw area, contralateral. Okay, so Marcus Gunn pupil is very interesting. It's a damage to the optic nerve. So the afferent pupillary reflex is abnormal, and there's like a jaw winking syndrome. So the eye will flutter when the jaw moves. Oh, look it up, it's really crazy. And you can also observe it during the swinging light test, but there is going to be partial dilation to both pupils. There's nothing really much you can do about this besides trying to see whether the damage is due to like a lesion or not. Okay, perinos syndrome is a lesion in the pretectal area, in particular the superior colliculus, and there's going to be a paralysis of the upward gaze. And there's damage to the rostral interstitial nucleus of the medial longitudinal fascicularis. However, there's normal down gaze, so this patient isn't going to be able to look up, but looking down is okay. There is going to be damage to the Edinger-Westphal nucleus as well, and there is going to be a retraction of the eyelids. So here is where the eyes are damaged. So cranial nerve 3, as you can see, is going to be okay. Horner syndrome, once again, I feel like we cover this all the time, is going to be a damage to the sympathetic nerves and the cervical sympathetic pathway. So the mnemonic is sample, so sympathetic nerve fiber injury, anhidrosis, so failure to sweat, meiosis, constantly constricted pupil, ptosis, so eye is going to be bulging out, loss of the ciliospinal reflex, and ophthalmos. And it's usually unilateral. Okay, so retinopathy, more commonly, is due to chronic hyperglycemia. And the chronic hyperglycemia is going to damage the capillaries, and from there the capillaries will leak blood, lipids, and fluids, which can be toxic to the tissue. The proliferative kind of retinopathy is chronic hypoxia. So those are going to cause more blood vessel formation, and that causes traction on the retina. So what does that mean, right? Traction on the retina. It's going to forge these fields into the retina, so there can be blood supply. But in forging these fields, you do damage the neural layer. Once again, the hypertensive damage is going to cause the proliferative the retinopathy, and it's going to cause something called a flame-shaped retinal hemorrhage, as you can see here, all these hemorrhages right here. The aterovenous nicking, along with cotton wool spots, microaneurysm, and the macula star is going to be observed in the fundoscopy. So here's the nicking. Here are the exudates from the damaged capillaries. Okay, so retinal vein occlusion is going to be due to the compression of the arterial atherosclerosis, and it will cause retinal hemorrhage along with venous engorgement and edema. Central artery occlusion is acute and it's painless, monocular vision loss. So this is going to be accompanied by cloudy retina with attenuated vessels and the cherry red macula. Papillary edema is the optic disc swelling up to the increased intracorneal pressure, and there's going to be an enlarged blind spot that gets bigger and bigger, along with an elevated optic disc with a blurred margin. So optic disc is usually nice and clear. Here's the blurred margins. And leukorrhea is the loss of the blood vessels. So there, when you take a picture, right, it's going to have like a cat's eye reflect. And that can be due to retinoblastoma. This is the one we need to be most careful about. This is the most common childhood cancer. Along with congenital cataracts due to any form of congenital infection or toxic cariosis. So this is a particular bacteria that lies in cat feces and can pass the placenta. So pregnant mothers should be very, very, very careful about handling cat feces, especially when they have small children around, newborns, and while the child is in the womb. Strabismic amblyopia is going to be a problem with the stereoscopic vision because, once again, the eyes are not aligned, so the visual aspects are not parallel. The fovea vision is going to be suppressed in the non-dominant eye, leading to blindness if not corrected. And it can be corrected within the first 6 months of life, so it is reversible. The most common form of treatment is patching. So you put the patch on the good eye in order to strengthen the muscles of the bad eye, and after 2-3 weeks of therapy, the eye is now strong enough to accommodate normally. In really bad cases, there can be a surgical shortening of the eye muscle. That's it for now. Thank you for your attention and good luck studying.